For those who haven't joined us, we just want to give you a little bit of an overview about what the Grand Round aims and sort of objectives are. Um, Dharura is a global emergency care health partnership. It's based out of Bristol in the UK with a affiliation with Nanyuki Teaching Referral Hospital in Kenya and has been for the last number of years. We're working in a partnership, and we want to support an ethical, sustainable, equal and reciprocal global emergency care and community health partnership, which allow health systems and their team to gain mutual development through sharing knowledge, skills, and innovation. So this is one facet of that. We're very fortunate today to have Viraj Bharambe join us, who is, as I mentioned, maybe for a few people on the call before, a good friend of mine. I've known him for a long time. He's also a consultant neurologist at the Walton Centre. Bit of background to Dr. Bharambe. He studied medicine in the University of Southampton, and he's completed his postgraduate medical training in Cheltenham, Gloucester, and London. He undertook neurology training at the Walton Centre, which is in Liverpool, and special interests in cerebrovascular medicine and epilepsy. His clinical work includes general neurology, stroke clinics, as well as neurology outreach at Aintree University Hospital. His special clinics at the Walton Centre include first seizure, complex epilepsy, and complex cerebrovascular clinics. Of interest as well, he leads placement for Edge Hill University and travels to the, I'm going to get this wrong, Universidad Católica de Mozambique for 2 weeks a year to deliver the neurology block for medical students and help train postgraduate doctors. So Viraj has a wealth of knowledge. He's very welcome to answer any questions you may have throughout the talk or at the very end. So if you have any, put them up, your hand up, or if you want to post anything in the chat, please feel free. So without further ado, I'll hand you over to Dr. Bramley.
Superb. Thank you very much, Chris, for that very nice introduction. I don't think I've ever been introduced so nicely. Okay, so just to check a couple of things, can you see where we're going? Where's my? Of course, for some reason it's closed itself down. So just whilst that's opening up, yeah. So I've been asked to do a chat today on essentially loss of consciousness and why it might happen, what the differentials are, and how clinically. At the front door, like many of you are from around the world, you can try and differentiate what the cause is, so that you can do your best for your patients. Can you see my screen there? And if I start playing, will we see that? Okay. Fantastic. Okay, great. So I've got an hour, and as Charlene said, I'll try and do sort of 45-ish minutes of chatting, and then maybe leave a bit of time for questions, because whichever strand of medicine or surgery or general practice you're all in or hoping to be in one day, you will come across transient loss of consciousness, and I think it's something that we all need to be very confident with. So I've kind of titled this as question mark seizures. This is a notation that we use in sort of British hospitals quite a lot, and it's often as a neurologist, the referral I get from GPs, A&Es, various parts of the healthcare system, they'll just say, "Dear Dr. Bharambe, can you see this patient for question mark seizures?" And then that's my job. That's what we start with. So as Chris said, I do this a lot in Liverpool. So let's get started. So aims and objectives: to be more confident in assessing and managing patients admitted. Let me just try and move this way. Admitted with transient loss of consciousness, TLOC, and things that shake, because we get a lot of referrals for that as well. Outcomes, hopefully, an improved understanding of the relevant terminology, because so much of this is about language and how we use it, and not only what it does, what it means to you, what it means to another healthcare professional when you're communicating that, and also what it means to the patient and their family when you give them particular diagnoses. And to develop your clinical approach to patients presenting with transient loss of consciousness. Okie dokie. Fine. So firstly, just to be aware, these are mainly UK statistics, but let's see where we are. So 1 in 2 people will experience transient loss of consciousness. So there's about 20 odd people on this call right now, and usually when I do these kinds of talks for medical students or postgraduate doctors, I generally say, can you put your hand up if you've lost consciousness before? And I certainly have, and I'm sure if we were to ask the team here, the room here, they'd all agree that about half of people in their lifetime will have experienced transient loss of consciousness. It accounts for 3% of all A&E attendances. It accounts for 1% of hospital admissions, and 1 in 20 people in their lives will have a seizure. That is 5% of the population in the UK will have a seizure at some point in their life, which is probably more than you were thinking, but that's what it is. In contrast, 1 in 120 people in the UK are affected with epilepsy. All right? Fine. So that's just some background statistics. Let's get to the fun bit, the clinical part. And really, when someone comes in with transient loss of consciousness, these are the 3 things that I'm thinking about. And these are the 3 things I'm going to be talking about today. Now, obviously, there are other differentials for why someone might lose consciousness. There's, hypoglycemia, cardiac arrest. There's all sorts of reasons why someone might lose consciousness. But in situations like hypoglycemia and cardiac arrest, most of the time, whether it's a paramedic or the emergency physician, those kinds of things you can diagnose pretty quickly. So they're not going to get to the point of someone lost consciousness and I don't know why. Usually it's these 3 diagnoses that we're thinking about. Okay. And I think,
yes,
as with so many things in medicine, as long as you have an approach, a clinical approach to how you're going to ask questions around it and how you're going to probe what happened, and you apply that approach every time, 1, you get better at that approach, and 2, you're much more likely to get to the answer. So this is the approach, and I'm sure that most of you pretty much take this approach when you come across most sort of medical presentations. But simply speaking, I've put it down kind of in a textbook fashion there, how you would approach it. But how I approach it, or how I teach people to approach it, is it's very simple. Be curious. Just be interested. And if you're interested in what happens before the event of loss of consciousness, what happens during the event of loss of consciousness, and what happens after, that's much easier to remember than this long list. As long as you approach it with a certain level of interest and curiosity, most of the time you'll probably get to the answer if you know how to interpret what the patient is saying. So, before, what was the situation? What was trigger? If there was one, were there any prodromal symptoms? So that's what's happening before. During, very difficult. The patient lost consciousness. They're not going to know very much about what happened during the event, but a witness will be able to tell you what happened during the event. So again, being a bit interested, going that little extra step and calling someone on a phone, or if they've come along with a relative who witnessed it, being curious and asking what happened during. And then afterwards, were they confused? Were they sleepy? Did they have any injuries? All that sort of stuff. We'll get into the details of this in a second. So the main first point to take away is be interested, think about before, during, and after, and you'll probably get to the answer. Good. So rather than showing you the videos at this stage, actually, let's do it. I've got time. I was going to speed through this because I thought I only had 25 minutes, but let's do this. So I want you to see these 3 videos. You will see them again later, and I'm not going to tell you what's going on, but you just have a think about what you think might be happening. So this lady's having an EEG. So this is in the neurophysiology department. She's got lots of leads on her head, and we are flashing some lights in our eyes. There's no sound to this video, but you can. Everyone can see the video, right? It's playing. Great.
Further introduce the patient.
Okay, so that's video number 1. I'm going to go on to video number 2. So maybe you have some thoughts about whether you think it's syncope, seizure, dissociative seizure? You have a think. Okay, there's 3 patients there, obviously, but all the same etiology, all the same cause. So have a think about what you think that is. And then this is video number 3. This one has some sound, and sometimes it can be a bit loud. So if you don't want it to be too loud, just have a look at the volume on your phone.
Or you can collect favorites and shoot them. We have a little miniature spirograph.
It also has leads on.
You know what a spirograph is?
It
It makes little designs. It's like a gear. You put your pencil in holes in it, and anyways, it makes all kinds of different designs. Once you guys go out, the nurses are going to be coming in. Hi. Not a problem.
Good. Okay. So that's the 3 videos. If it helps, each of those is a different diagnosis. So I've not given you any tricks there, and they are all different diagnoses. So one of them is syncope, one of them is seizure, and one of them is dissociative seizure. So have a think what you think it is, and we'll see them all again later, and I'll kind of talk you through how I'm interpreting them. All right. Great. So that's the videos. Let's move on to some cases, just to keep you thinking, because it is it's the end of the working day here in the UK, and it's about the time that I usually stop thinking. So you can become very passive. So keep it a bit interactive. So the first case, a 33-year-old builder. He's out shopping with his family. He felt strange for about 10 seconds before collapsing with loss of consciousness. According to the paramedic report sheet, he lost consciousness. Oh, sorry. He lost consciousness and his limbs were jerking. He bit his tongue and was incontinent of urine. And he admitted to feeling confused afterwards. Okay? So, what do you think? Is your 5 options multiple choice? Do you think it's a seizure? Do you think it's syncope? Do you think it's a dissociative event? Do you think it's something weird and neurological? Or do you think you need more information? Anyone feeling brave? That's fine. We don't have to. But these are the kinds of options that we're thinking about. So my view on this would be looking at.
Viraj, you've got a few answers in the chat. I don't know if you can see the chat.
No, for some reason I can't see my own mouse on all this, so I'm kind of trying to. But yeah, can you read out what the overall? So what are most people thinking?
We've got 5 people saying seizure currently, with no other takers.
Fine. So that is exactly the trap I was trying to set. So I totally understand why someone would think seizure, because here we have so many pointers to what sounds like a seizure. Okay, he has a strange feeling beforehand. He loses consciousness. There is some jerking and shaking. He bites his tongue and he's incontinent of urine, and he admits to feeling confused afterwards. Okay, and this is often the kind of referral I get from A&E, from GP, from wherever, because we are taught at medical school that these are good delineators, as in good differentiating clinical factors between syncope, seizure, and dissociative event. And I think what I want to try and get across today is, for most of you who are working doctors, I presume, there is more nuance to this. And the thing with asking the questions in the history of patients and relatives is you can very easily lead the answer if you're not careful. Okay? So let me show you. So we said that he had a strange feeling beforehand. What do you mean by strange feeling, sir? Is really the question to ask. As I said, be interested, be curious. On direct questioning, he admits to feeling hot, sweaty, and nauseated. What does the witness say? Well, the witness says, yeah, there was some shaking or jerking of the limbs, but it was irregular. There were intermittent body jerks on one side and then the other, every 1 or 2 seconds. And then on asking about the aftermath, on waking, he had bitten the tip of his tongue, and he remembers waking on the floor with the family stood over him. Okay? So hearing about all of that, do we want to revise what we think the answer is, or do we think that it's still likely to be seizure?
So I don't know if you can see the
Yeah, I'm going to need your help with this, Chris. So whenever I ask a question, if you could have a look in the chat, sorry.
chat, man. That's not a problem. We have 3 syncope, 1 still seizure.
Yeah, fair enough. Very good. So I've converted a few with my answers there. Let me explain. So syncope, what do we mean? What do we mean when we say syncope? We mean that for whatever reason, the heart and the vasculature going up towards the brain was unable to maintain blood pressure for long enough that the brain realizes there's not enough blood getting here. It causes loss of consciousness, and it drops you so that you are flat and you're not having to fight gravity to get blood to your brain. Okay, that's essentially the physiological, what's going on in syncope. Now, the most common form of syncope we know is vasovagal syncope. Okay, so that is not enough vagal tone and not enough blood pressure. There's all sorts of other types of syncope. There's cough syncope, micturition syncope, laughing syncope. It gets weirder. But the point being, no matter what your trigger for your syncope, what it is just not enough blood getting to the brain. Okay. And what is the typical perception? What did the patients say they experienced during this event? Well, they say they experience it would often be in a crowded bus. They'll be hot, emotional, and be after prolonged standing. Very common triggers are things like venipuncture, and as I said earlier, coughing or urination. There can be some prodromal symptoms, and this is what the gentleman in our case was talking about. He was saying that he felt lightheaded, he felt hot, he felt sweaty, nauseated, blurred vision. And this is what I mean. If anyone has ever passed out before, it is almost certainly because you had vasovagal syncope. I remember when I was at medical school, we would have the dissection room in our first year. We would go into the dissection room with our coats on, with about 30 of us, and you could almost guarantee the first time that 30 18-year-old kids went into the dissection room, at least 2 of them would start feeling quite faint or actually faint. And they would all have said to you, I feel lightheaded, I've got ringing in my ears, I've got blurred vision, I'm nauseous. So these prodromal symptoms, be interested and ask about them. Okay? The witness account, yes, okay, the typical thing we read in textbooks is pale, floppy limbs, motionless. But the thing they don't tell you, and I'll show you the video in a minute, is that there is often, in at least 50 or 60% of cases, minor and intermittent jerking. The aftermath, well, they will have a memory of waking where they fell, okay? And they'll be back to normal very quickly. What do I mean by very quickly? Within a minute, they will be, within 30 seconds, they'll be able to recognize their relative or friend. They will recognize where they are. They will know the day, the date, the year. Within, 20, 30 seconds, 60 seconds, they'll be pretty much back to their normal selves. They'll be embarrassed. but otherwise they'll be back to their normal self. And risk factors, well, that's young females. Young females generally run lower blood pressures. I don't need to tell you guys that. You do your vitals, and almost any woman under the age of 25 will have a blood pressure of 101 over 60 something. So they're already at a low threshold and more likely to pass out. So let me show you. So let me just show you this video again. Right. So this video is essentially this was done in Berlin in the late 80s, just after the Berlin Wall fell. They took 100 medical students and they made them do something that makes you have syncope. So you get someone to crouch down, hyperventilate, so for about a minute, and you get them to stand up quickly, and this person's pressing on their chest to decrease their vena cava return, their venous return. And within about a few seconds, the person will pass out. Okay, so these are all induced syncope cases. Okay, so the same as any other vasovagal syncope you will see. And you saw this video earlier, and I think you would be, it would be fair if a relative or a paramedic or even, frankly, healthcare professionals saw some of this jerking and thought maybe this is seizure activity. Especially these last two. These are both also syncope, but you can see why a paramedic or a healthcare professional might think this looks very much like a seizure because it's shaking and jerking. And that's because I don't think we communicate in medical education well enough that shaking and jerking in and of themselves, this one, for example, looks a lot like a seizure. And I don't think we communicate in medical education well enough that shaking and jerking in and of itself is not a good delineator between seizure and syncope. In fact, it is the whole picture, like we have described before. It's all of these things put together that make you think more seizure or syncope. Okay, so just before we leave syncope, some common pitfalls in diagnosing syncope as the cause of transient loss of consciousness: not eliciting a detailed account of prodromal symptoms. So when someone says, I felt funny beforehand, like something was going to happen, that does not always mean they're having an aura. Okay, actually, you need to be a bit more interested in what do you mean by felt funny? Oh, lightheaded, nauseous, sweaty, ringing in my ears. Okay, sounds a lot like syncope. Not taking a history from a witness is a common problem. How can you tell if you don't know what happened during the event? Not appreciating that most people who faint jerk slightly, and hopefully that video from the Berlin Medical School evidences the fact that jerking happens in both syncope and seizure. I will show you a seizure video later and show you how different it is from a few minor intermittent shakes and jerks. Reading too much into biting the tip of the tongue or urinary incontinence. You see enough syncope and you realize that as they fall, as like in those videos, they had a crash mat. You see how hard they fall, some of them. If you fall that hard and you have lost consciousness and your tongue is just through your teeth, you will commonly bite your tongue. The tip of the tongue being bitten is very common in syncope. It's the back or the side of the tongue being bitten that you see more in epilepsy or seizures. Urinary incontinence, again, if you notice in that video from the Berlin medical students, they all had nappies on because many of them would lose continence. When you lose consciousness, you lose continence. It doesn't mean you've had a seizure. And not realizing that anybody who has a blackout will answer yes if you ask them they were confused. So in this case, for example, in our 33-year-old builder, the paramedics will come along and he'll have recovered. And if you say to him, were you confused afterwards? Of course he will say yes, because he's never passed out before. He's never lost consciousness. The question is not, were you confused afterwards? The question is, when you woke up, did you recognize everything around you and your family? When you woke up, were you doing sensible things? Or were you aggressive? Were you combative? Did you not recognize your wife? It's asking what way you were confused. Because again, I've passed out before. When you wake up after fainting, of course you're confused. You've just fainted. That is not the question to ask. It's being specific about in what way were you confused and for how long were you confused. People with a seizure or an epileptic seizure will be confused for 10, 20, 30 minutes afterwards. They will be fighting the paramedics. They'll be angry with their wife. They'll be moving things around the room and don't know why. They'll be all over the place. Okay, it's a very different kind of confusion to a bit embarrassed and didn't know how I got to the floor. Good. Okay, so before we leave syncope and go on to the next one, any questions so far? I'll just escape from that and have a quick look at the chat. Questions?
There are no questions in the chat at the moment.
Okay. That's fine. If any questions arise to people along the way, or you disagree with me, or you want to bring anything up, please pop them in there, and hopefully Chris and Charlene can tell me if I'm being told off by any of you. Good. Great. Right, so let's move off syncope. Right, so before we go on to the next video, this is the bit that I wanted to make sure we're all happy about, which is language, okay? The problem is, neurologists can be a little bit difficult, and we can keep making new classifications and terminologies for all these things, okay? And this leads to a lot of problems, okay? And these are the kinds of problems it leads to. A patient will come along, and they may have had seizures for years, and they will say to you, I have petit mal seizures, doctor. A general physician, or a internal medical doctor or whoever might say, please see this person as they're having absent seizures. The neurologist will say, this patient is having complex partial seizures. The epileptologist will say, this patient is having focal dyscognitive seizures. And that's because all of them have different levels of remembering when they last had epilepsy training, okay? So your generalist last had epilepsy training when they were in medical school, probably. The neurologist probably had, 5-10 years ago last learned the previous WHO or the ILAE terminology, and so they're using old terms. And the epileptologist, who has to read all these things, keeps up to date. So we're all using different words, and the problem is we're not speaking the same language, and often that can lead to confusion and problems, all right? So I'm going to simplify things. Basically, there are only two types of epilepsy in the world. That's it, okay? There is focal onset epilepsy, and there is genetic generalized epilepsy, all right? The simplest way of thinking about these are, well, firstly, focal onset epilepsy is the most common form of epilepsy worldwide, right? So if you take 100 people with epilepsy, 80% of them will have focal onset epilepsy. So just straight off the bat, probability-wise, if you see someone with seizures, they probably have focal epilepsy, right? What do I mean? What are these differences? So let's talk about focal epilepsy first, because it's the most common format, okay? When I say focal onset epilepsy, what do I mean? I mean that at some point in that person's life, they acquired some sort of lesion. This could be a developmental lesion, this could be a stroke, tumor, a bleed, infection, neurocystic psychosis, I don't care. Any lesion that warps, or twists, or damages the grey matter, the cortex of the hemispheres, can cause a focal seizure. Okay? And wherever that lesion is, will be the place from which you get all of your seizures. Okay, so for example, if I have a lesion in my left sort of posterior frontal hand area, in the hand area of my motor cortex, okay? Let's say I had a small stroke there. Every time I have a seizure, I will start by getting hand twitching. That may progress on to hand and arm twitching, which may progress on to generalization across both hemispheres, and then I go into a full tonic-clonic seizure. Okay? But every single seizure I have will start from that lesion, that area, the motor hand area on my left. So I may come to you and say, sometimes, about 2 times a week, I get just hand twitching, and then it stops. And about once a week, I get hand twitching, it spreads up to my shoulder, and then it stops. And about once a month, I get hand twitching, goes to my shoulder, and then I lose consciousness, and I wake up, I've bitten my tongue, and I ache everywhere, and I'm confused. What are they saying? What they're saying is that they've got focal onset epilepsy coming from that area every single time, and that may or may not spread and eventually generalize to the entire brain, depending on the brain's own anti-seizure mechanism. So the brain itself can imprison and stop the seizure from spreading. And depending on how good the brain is at doing it that day, either it will keep it to a very small focus and just my hand will twitch, or the seizure will start winning and everything will twitch up to my shoulders, or the seizure will completely win and I'll have a generalized tonic-clonic seizure. So what is this? What do we call this? They're having the same thing every time. We call this stereotypy. And that's the main clinical feature you're looking for when someone presents with recurrent episodes of loss of consciousness. Is it the same thing that happens each and every time? And do you just go to a different point in the sequence? Do you sometimes have hand twitching and then nothing else? Sometimes hand twitching going to shoulder twitching, and sometimes hand twitching progressing to loss of consciousness and generalized tonic-clonic seizure. Okay? But the seizure will always start from the same lesion and may or may not spread. They will demonstrate stereotypy, and it will be the same thing every time. So if I have a lesion in my left hand area, it will start in the hand every time. If I have a lesion in my left occipital lobe, the visual regions, what I'll tell you is, doctor, in my right visual hemifield, because that's what's represented on the left occipital lobe, I always get funny amorphous colored shapes, but they're always the same shapes. And then I lose consciousness. That means they're having a focal event in the occipital lobe, which is spreading and generalizing. Okay? It may come from the temporal lobe. Now, the temporal lobe is where things get tricky, because the temporal lobe, you can have focal events, so an event just imprisoned and staying within the temporal lobe, which causes loss of consciousness. This is what in old terms was called complex partial seizures, but today we just call it a focal seizure with loss of awareness. Okay? So they will commonly say, first, doctor, I get this rising sensation in my abdomen, and then I get a sense of deja vu, this sense that I have lived this moment before. And then that will progress on to me. I then lose consciousness, but my relatives or the witnesses will say that I smack my lips and I'm picking up my clothes, or I pick up something near me and I fidget with it, or I do hand wringing like this. So they are having a focal seizure, but because it is in the part of their brain that subserves consciousness, they lose consciousness and they carry out automatic activities, things like lip smacking, things like this. So they're not having a generalized tonic-clonic seizure and losing consciousness. They're losing consciousness because the seizure is within the area of their brain where consciousness is important, and they're doing automatic activities. Now, they may go on to have all this and then go on to have a generalized tonic-clonic seizure. Same as the hand area, same as the occipital area. Okay? So, but the key point being, they will say, I experience this every time. Rising sensation, nausea, deja vu, and go on to have the seizure. All right, so that's focal seizures. That's 80% of what you will see if you see epilepsy. All right, and importantly, what do I mean by this in terms of EEG? So if I put an EEG on you, so if I put an EEG on my head when I'm having this hand seizure, what I'll see is from the area where my EEG is looking at my hand area, you'll start seeing, as you can see on the left of your screen, this sharpened activity start occurring in one area of the brain. And then you'll see that it stays in that area before it starts spreading, and then the whole brain starts having activity. Okay, that is focal onset seizure with secondary generalization. Okay, and you can see on the EEG how that's so different. This, as I said, was 80% of epilepsy. This is the other 20%. Okay, so we call this really nowadays genetic generalized epilepsy. In these cases, it is not that someone has acquired some sort of lesion on their brain. In these cases, it is that they have some sort of genetic abnormality, which in almost all cases will be a channelopathy. Okay, so they have some genetic mutation that means that either their sodium, potassium, calcium, or chloride channels are abnormal, and therefore all of those channels within their brain are abnormal. So when they have a seizure, you can see here, this is all normal on the left, and then all of a sudden, boom, the whole brain goes off all at once. You can tell that's pathophysiologically very different at a brain level and a channel level compared to what we were seeing earlier. There is no start in one area and spread to the rest. This is something is intrinsically abnormal within the channels of the brain. Yeah. So this is probably best conceptualized. All of these genetic generalized epilepsies are best conceptualized as genetic conditions, right? So what I mean by that is that if someone has a seizure that comes on before the age of 25 years old, it could be focal onset or it could be genetic generalized epilepsy. Okay. If their first seizure comes on after the age of 25 years old, 99.9% chance it's focal onset epilepsy. Genetic generalized epilepsy does not come on after the age of 25. Okay, so fine, you've got someone in front of you who's 18 years old with their first seizure. How do you know whether it's genetic generalized or focal onset epilepsy? Well, they come with this collection of symptoms. So whilst I told you in focal onset epilepsy they get the same stereotyped event each time, what you'll see in someone who has genetic generalized epilepsy is over the course of their childhood and their adolescence, they had various types of events. So in their childhood, they may have had blank spells, just absences. Okay, so an absence is not the same as a complex partial seizure. An absence is, I'm talking like this, I'm having a conversation with you, and then all of a sudden I stop and then carry on as if nothing happened. Okay, it's very brief. They have almost immediate recovery afterwards, so no post-ictal state. And they're not doing all of this automatism stuff that you see someone do during a focal onset event with loss of awareness. Okay, so they'll have absences in their childhood. In their teenage years, they'll have myoclonic jerks, right? Often in the early morning, they'll say, oh, I'm having my breakfast in the morning, doctor. All of a sudden, I'll just fling the cereal across the room and it makes a mess. I don't know why I do it. It just happens and I have no control. And then by the time they get to 18, 19, they'll start having generalized tonic-clonic seizures, or they'll start having atonic seizures, all of a sudden lose all tone in their body. Okay? But when you do the EEG for any of these types of seizures, all of them will look like this. Normal, normal, normal on every single lead, and then across every single lead, the brain goes off. Okay? So that's genetic generalized epilepsy. So that's it. There's two types of epilepsy in the world: focal onset epilepsy and genetic generalized epilepsy. Focal onset epilepsy, much more common, 80%. It's due to a lesion that you have acquired. It will always present with the same sequence of movements. See, the same sequence or same pattern. You may go only up to stage 1 of the pattern. You may go to stage 1, 2 of the pattern. You may go all the way to the stage of generalized tonic-clonic, but it will be the same pattern. Whereas with genetic generalized epilepsy, less common, always comes on before the age of 25, and the EEG has a very particular signature. Okay, that's it. That's epilepsy made easy. All right. Good. So you'll remember the videos from syncope, and hopefully you'll see in this video now how this is so different. Again, this video is a little bit loud. Let me. I'm going to play it, and I'm going to talk you through how I'm interpreting it. Okay. So he's colouring. He's got his EEG leads on, and you'll see there. He's still colouring, it's all okay, and he's paused, he stopped. He then turns his head to one side, that's head turning, that you see that in focal onset epilepsy. One hand goes up like this, and the other hand goes straight out like this. The one flick, there we go. There's this initial cry. So this is the tonic phase, okay? Why do we call them generalized tonic-clonic seizures? Because that's what happens in that order, right? First of all, you have increased tone. He's incredibly stiff. And then you'll move on to the clonic phase where he has clonus, okay? So there is a pattern to what happens in seizures in a way that there isn't with syncope. The jerks that you saw with those students in Berlin, they were just happening irregularly. You couldn't predict when that jerk was going to happen, right? Whereas with this, he goes into a tonic phase. He then goes into a clonic phase. So, oh God, that's annoying. Sorry, I'll try and... Back to where we were. So,
it makes all kinds of
flexed arm, head turn to one side. That's this. And this is the high tone, increased tone. That increased tone is also what's making him cry out. So sometimes patients and relatives think that the patient is in distress or in pain because of these seizures. They're not. What's happening is all the intercostals and the diaphragms are contracting, and they're basically pushing the air past contracted vocal cords. This is not the patient in pain. Whilst it looks very painful, the patient has no idea what's going on. They're completely lost consciousness. Okay. So this is the tonic phase. Increased tone, very high tone, incredibly stiff. If you tried to bend his arm right now, you almost wouldn't be able to. And now he's transitioning from a tonic phase into a chronic phase. The movements are symmetrical. Both arms are doing the same thing. Both legs are doing the same thing. So this is the clonus, right? He's gone into the full chronic phase. And as you'll see, the chronic phase will slow and slow and slow until it stops. Okay? Now.
He does? Okay. Yeah. Okay. And he quite often loses bladder control. Okay.
Good. So you'll see that there's a pattern to how this progresses. It builds. It's rather explosive in its onset. It kind of goes into this movement, and then there's a high tonic phase. There's this big kickoff of how it kicks off, and then it stays a tonic, and then it kind of goes. There's a chronic phase, and then it slowly peters out like this. There's a peak and a trough to how the whole thing progresses. Okay. Good. So, convulsive seizures. Going back to our previous template of sort of situation, trigger, prodrome, all these things. What kind of situations do we see a typical first convulsive seizure in, which is often what you guys are seeing in ED? Guys, I'm doing terribly for time, aren't I? Sorry, I realise I've already been at 50 minutes. Let me try and keep this going. So, alcohol.
Fine, you're fine. Keep going, mate.
Okay. All right.
Yeah.
Sorry, I've gotten very excited. I apologise. Trigger. So there can be none, but flickering lights can sometimes be the case. Prodromal symptoms. Okay, maybe there can be none, but they can have the aura. So my aura, when I have my left frontal lesion, is my hand twitching. That's the aura. If I have a temporal lobe lesion, my aura is the rising sensation, the deja vu. So when we really say aura, what we mean is the beginning of the focal seizure. That is still the seizure. Okay. Witness account, they'll often say there's this initial cry, like we saw in the video, this crying out as everything contracts and the air is pushed out. Stiff limbs, not jerking limbs, stiff limbs. I could not move him. Yeah. Blue lips, altered breathing, and synchronized, symmetrical jerking movements, which is not quite what we saw in the syncopal events. Yeah. Aftermath, very delayed recovery, lateral or posterior tongue bites, waking with the paramedics' presence. The patient will often only be aware when the paramedics turn up or when they're taken to hospital. There is a big period of where the patient is not conscious, but to the witness or to the relative, it will look like they're back to normal, but they're not. Okay. And injuries, obviously, broken limbs, burns if they fall against a heater or a fire or a radiator. It is a first seizure. Now, so I guess this is going to differ quite a bit between what you do in Kenya and what we do in the UK. So I'm going to kind of accelerate through this a little bit. But this is kind of relevant. Now, I'm not sure. So when I work in Mozambique, this is kind of not so relevant because I know that, and I'm not sure what the healthcare system in Kenya is like, but the reason I made such a big deal of differentiating focal onset epilepsy with secondary generalization and genetic generalized epilepsies is because the treatment is okay, and it's quite different. So for focal onset epilepsy with secondary generalization or without secondary generalization, there is no contest anymore. There's no debate. Lamotrigine is the best drug on any metric you want to choose. So chance of seizure freedom, tolerability and side effects, cost effectiveness, choose your metric. Lamotrigine is by far and away the best drug for focal onset epilepsy. So for most of the epilepsy you see, lamotrigine is the best. For genetic generalized epilepsy, by far and away, sodium valproate is the best. Okay. Again, chance of seizure freedom, tolerability. The problem with sodium valproate, as you're probably all very aware, is teratogenicity. So there's a 5 times increased risk of fetal malformations to kids that are born to mothers that are on valproate. So there's lots of sort of stringent restrictions on who we can give valproate to. So in lieu of that, whether you're in Kenya or in the UK, if you can't really give valproate to a young woman with genetic generalized epilepsy, actually lamotrigine is the second best medication. So in general, that's kind of made life a bit easier for most generalists. Lamotrigine is probably your best option. Now, in ED, this is not often the case because lamotrigine, annoyingly, only has an oral formulation. So what you're going to go with if someone comes in with status epilepticus is either phenytoin, Keppra, or valproate, because they can all be given IV. And that makes total sense. You should do that. But if someone comes in with, let's say, a self-limiting seizure and a self-limiting seizure they had 3 months ago, and you want to start them on something, the best thing to start them on is lamotrigine. So if it's an emergency situation, you need to stop the seizure right now, absolutely do what you always do, benzodiazepines, and then load with Keppra, phenytoin, or valproate, whichever one you prefer. Okay. But if you have a bit more time and they're having self-limiting seizures, lamotrigine is in their best interests. Okay, good. This I'm not going to go through because it's not that relevant to you guys. This I'm going to quickly touch on if I can, Chris, just very quickly, because I'm going to quickly talk through how it's different.
So you've had some really lovely positive comments about how it's everyone's really enjoying this. So don't be afraid to go over, is what I'm going to say.
In that case, let me just talk through this video. So you'll see that this patient's having lights showing in their eyes. Now, you'll see that there's an explosive onset. Okay, all of a sudden, boom, straight into asynchronous and asymmetrical lower limb shaking. Then it kind of peters out. It doesn't do very much, and then the the sort of amplitude increases again. It has what we call a waxing and waning. So it kind of increases in frequency, decreases in frequency, increases in frequency, decreases in frequency, and that is very different to what we saw earlier with the chap having the temporal lobe seizure, because he increased and then slowly petered out. Whereas this video has explosive onset and then increase in amplitude, and then it calms down a bit, and then increases in amplitude again, it calms down a bit, which is a very different pattern. It's called what we call a waxing and waning pattern of activity. Okay, you'll also see that here, rather than an initial cry at the onset, there is hyperventilation. You see her hyperventilating there? And there's bicycling movements, asynchronous, asymmetrical movements. This is not what we saw with the patient that was having the epileptic seizure, okay? So this is a dissociative seizure. This is the terminology we're using at the moment. You probably have used the word pseudo-seizures before, or non-epileptic attacks, or psychogenic non-epileptic seizures. All of them mean the same thing, okay? We use the term dissociative because diagnosing something as non-something doesn't really make a lot of sense. We don't really do that in any of the rest of medicine. We don't say, sometimes we say non-cardiac chest pain, sorry, but I don't agree with that diagnosis either. So we shouldn't diagnose something as not something else. We should diagnose something as what it actually is. And what these patients are doing, as far as we can understand, is dissociating, as in separation of mind and body for some reason. So as you can tell, the situation here is quite different. It's an explosive onset rather than this kind of build-up of tonic phase. The trigger is something stressful often triggers it. The witness account will be flailing and thrashing movements, asynchronous, head shaking. Now, you have to think about what's happening when a head is shaking. To shake a head, you have to contract this sternocleidomastoid muscle, then this sternocleidomastoid muscle. And to do that, that means that the seizure is doing this on this side and this on this side. That's not how seizures work. They don't go in opposite anti-clockwise directions. They would go together, okay? So you might get head forward, you might get head back because both are contracting symmetrically. You would not get shaking of the head. You might even get head going to one side, but you won't get shaking back and forth, okay? Pelvic thrusting is very common, and they may wax and wane like I showed you before. And sometimes they may say that actually all of this shaking is going on, doctor, and I'm aware that I'm shaking. You cannot be shaking on both sides and maintain awareness. If it's an epileptic seizure, you won't shake on both sides and maintain awareness. That's just not possible, okay? So it must be dissociative. Aftermath, no postictal phase, but that can change. And the risk factors Female 70%, but 30% are male, so be aware. And a psychiatric history 90%, but also psychiatric history is very common in patients with seizures, so I wouldn't use that as a good delineator. Make this diagnosis based on what you're seeing and why it fits this diagnosis, not why it doesn't fit seizures. I'll explain this now. So we have good data now that these are the kinds of things to look for, all right? So these are excellent sensitivity and specificity numbers. So just to tell you, with specificity, if the sign or the clinical symptom is there, you're very likely to call it a dissociative event. So if you have more than one of these, you can be very confident that what you're dealing with is a dissociative event. So eyelid fluttering doesn't really happen in epileptic seizures, but 100% specificity with eyelid fluttering in dissociative events. Ictal crying, so if the patient is crying during the event, probably not epilepsy. If there's pelvic thrusting, which is what this photo shows up here, this does not happen in epilepsy. It does happen in tetanus, but it does not happen in epilepsy, okay? Side-to-side thrusting, okay? Fluctuating course, this waxing and waning course, 96% specificity. Preserved awareness, if the patient says, I'm aware that I'm shaking when I'm shaking on both sides, 96% specificity. Asynchronous movement, so that's what the lady was doing in the video, where the legs were cycling, bicycling movements, that's asynchronous. And then eyes closed. And when I say eyes closed, I mean eyes firmly closed. So when you go and open their eyes, if they resist, that's close to 100% specific. And that's the references at the bottom there for the paper if you're interested. A very good paper. Ictal examination, so that's just you looking from the end of the bed. That's just observation. You can kind of check this. If you want to examine them during an event, if they have an event in your department, you can look for these things. So when they're having the event, when you first go and touch them, as you touch them, does the seizure change in some way in response to your touch? That's almost 100% specific. Fluttering or blinking when you rub their eyelashes. When someone's having a seizure, they will not have any response. Their eyes will stay the same. Whereas fluttering or blinking on eyelash rub, almost 100% specific. And active resistance to eye opening is very suggestive of dissociative events. And what we call a geotropic gaze. So if they're doing, the thing that Austin Powers does when he's looking at his nose, so this kind of cross-eyed thing. So if they're cross-eyed, that's again almost 100% specific. Right? Again, that's the references down at the bottom. So this case is actually about someone with known epilepsy. That how do you manage someone with known poorly controlled epilepsy that's coming in with seizures? Now, I realise we're up past 6 o'clock, so I'm not going to go into this, but these are the common reasons why they present. And the only thing I wanted to touch on at the very end, I don't know. I feel like I don't need to teach you guys about status. I think you guys probably see more status epilepticus than I do. I only see them when all of this has failed and they need to be transferred for super refractory status. But I think you guys know this. Stage 1, some benzodiazepine, either IV or PR if you can't be given PO. At time point 2, which is often about 5 or 10 minutes in, a second dose of the benzodiazepine. At time point 3, give some sort of proper treatment, second line treatment. So that's either phenytoin, Keppra, or sodium valproate. All of them are equally efficacious, but probably phenytoin is the best. And then if that's not worked, by 20 minutes, 25 minutes, you should be calling your intensive care doctors or your anaesthetist to try and anesthetize the patient, because propofol will stop all seizures. That is the definitive treatment. Okay. Good. So, in summary, seizures are a clinical diagnosis, and a detailed history is key to accurate assessment. If you happen to see a seizure, describe what you see, not what you think you see. So, use some of the words that I've tried to get across today. Things like synchronous movements. Is there a waxing and waning quality to it? Does it build and then tail off? Do we see intermittent shaking and jerking, or are they going into a tonic and then a clonic phase? If you happen to see one, describe actually what you see, not what you think you see and what you remember from your medical school days. Okay. Most people do not require treatment after a single unprovoked seizure. Most people will have just one seizure in their life and never go on to have any other ones. People with epilepsy often have... these summary points are because of the slides I thought I was going to show, but I've significantly overrun. I'm very sorry. Fine. I've spoken about a lot there. I could speak about this for quite a bit longer, but I just want to get this across. So we have a free resource if you're interested. It's for everyone from medical students to generalists to neurologists. It's called neuropodcases.co.uk. So me and a few of my colleagues put this together. It's free on Spotify, Apple Podcasts, SoundCloud, or even if you just want to go to the website. And we have many episodes on transient loss of consciousness and seizure. And if you want to explore there, there's lots of episodes on everything neurological that might be of interest. So neuromuscular emergencies, myasthenia gravis, all the things that might interest A&E doctors. So have a look at that if you're interested, or if you just want help going to sleep at night. These are very helpful. Perfect. That's significant. An hour and 4 minutes. I know it's not. We started at 10 past. That's okay. It's less than an hour.
You will be forgiven, Dr. Bharambe. That was brilliant, and you've had a lot of plaudits throughout the chat there whilst you were doing it. So yeah, thank you very much for putting on the session. Before we close, I know there's a few people who maybe want to escape. It is past 6 o'clock. Feel free to leave. It's not going to be a problem. I will just post something in the chat. It's self-explanatory, and Charlene will talk about that in a second. But there's a few questions that I just want to ask from the chat, if that's okay, Viraj. And that's one question was, how do you differentiate with hysteria? Is the first question.
Yeah. So hysteria is the old term for what we call dissociative seizures. Okay. So hysteria is the old sort of Greek term for wandering uterus, which is what I think Galen used to think it was. It's clearly an outdated term and not one we use anymore. So I think I explained in the dissociative slides how we differentiate. So, asynchronous movements, waxing and waning, and those 2 slides that were showing the sensitivities and specificities, that's how we would differentiate with hysteria with very good accuracy. So I think if you find more than 1, 2, 3 of these signs and symptoms on those sensitivity and specificity slides, you can be pretty sure you're dealing with dissociative events, not epilepsy. Okay.
Right, and then there's one more question in the chat. I don't know if you can see it, but it says, "Great session, thank you." And that's from Sean Wright, one of the consultants in the ED in Bristol. Should we treat the patient whose focal seizure is presenting differently / progressing as higher risk?
So, Sean, if you're still there, would you mind just clarifying what you mean by that? So should we treat the patient whose focal seizure is presenting differently, as in someone who's known to have focal seizures but is presenting with a different type of seizure? Is that what you mean?
Yeah, that's it basically. So we know that patients that present with clusters or changes in their generalized pattern or frequency are potentially higher risk of sudden unexplained death, don't we? But actually, on your description, and I think traditionally and anecdotally, we do treat patients that they've always had partial complex and now they've had a generalized tonic-clonic. I think we have a tendency to maybe keep them in, maybe, treat them as higher risk. But on your description, that doesn't necessarily sound as if we're getting that right. Just wondered if you had a thought.
So I'm just trying to get my head around and make sure I answer this right. So there's kind of 2 scenarios here. So you have your patient with, say, a focal onset seizure where the hand always jerks, and now it's progressing on to have more generalized tonic-clonic events. Well, yeah, that's someone who's uncontrolled, right? So that's someone who needs either an escalation of their treatment, or we need to have a long chat with them about why it is their seizures are not controlled anymore. Usually, that is an intercurrent infection. It's medication compliance. It's I've taken up cocaine recently. Or it's it's a bunch of other lifestyle factors that means that they're not well controlled anymore. In the situation where someone with, let's say, the handshaking seizure starts getting a completely different type of seizure, so I used to get handshaking seizures, now I get weird colours in my eyes, or I get what looks like non-epileptic attacks, that's something I'd be concerned about. Is this person now getting dissociative seizures on top of their epileptic seizures? That's a really common scenario. For whatever reason, we don't understand, people with epilepsy develop dissociative events on top of that at some point in their course, and that's something we need to be, not over treating with anti-seizure medications, because we're just giving toxicity and clocking that early, diagnosing that, and making sure we explain to patients and relatives how to differentiate the 2. Have I answered the question? I'm not sure.
I think so, because that sounds like if they've only ever had complex partial, whatever we're going to call them, and actually now they're presenting with what sounds like a progression of that into it progressing into a generalized, they are potentially uncontrolled, and we should be a bit more cautious with them. Actually, that's great. Thank you very much. That was a great session.
Thank you very much.
Right, that's all the questions I can see in the chat regarding the talk. Personally, thank you very much, Bea, for doing that talk today. It was brilliant. And Charlene, just going to go through a few closing points just to round things up, if that's okay. Unless anyone else has any questions for Dr. Bharambe about that talk or anything to do with seizures or neurology in general. Great. So I'll hand you over to Charlene and she'll round things up for us. Thanks very much.
Okay, thanks everyone for joining, and especially big thanks to you, Viraj. Lots of good feedback. The next grand round will be on the 13th of November, but we'll disseminate the posters in advance. If you could all have a look at the chat and click on the Google form for some feedback, and that's the way you will get your certificates as well. So yeah, hope to see you next month and have a lovely evening.
Thanks very much for the opportunity, guys.
Thanks very much, Bea. And just to let everyone know that it is recorded, and we'll hopefully have this recording online if Bea's happy for that in the near future.
Sure thing.
Great. Thanks everyone.
Bye-bye.